Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. Today's episode is on switching to a 2-drug single-tablet antiretroviral therapy regimen featuring Dr. William Short from the University of Pennsylvania in Philadelphia. He'll take us through a case study and the data to support switching from 3-drug ART to the 2-drug single-tablet ART regimens, dolutegravir and rilpivirine, or dolutegravir and lamivudine, in virologically suppressed patients for whom nucleoside sparing or minimizing strategies may be warranted. This episode is taken from our series on key decisions in HIV care. You can follow along with the slides, which are available in the show notes. Let's get started and listen in to Dr. Short.
Hello and welcome to today's program, Key Decisions in HIV. Topic today is switching to a 2-drug single-tablet regimen, and this activity is provided by Clinical Care Options. My name is William Short. I'm an associate professor of medicine at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, and I will be walking you through today's topic. Let's start a discussion with a case study. This is a 43-year-old man well-controlled on a single-tablet regimen of rilpivirine FTC TDF who presents with worsening CKD and nephrotic syndrome. At that point, he was switched to rilpivirine FTC TAF as his estimated GFR continued to decline. Based on his history, he had tested positive for HLA-B5701, and he tells you that he would like to continue taking a single-tablet regimen. Some of the findings you have today at his visit are that his current CD4 count is 450, his viral load is less than 20 copies per ml. When you look back at his pre-therapy genotype, it shows wild type with no evidence of resistance mutations. He's immune to hepatitis B. He has no history, and by serologies is non-reactive to hepatitis C. However, he is immune to hepatitis A. His current serum creatinine is 2.5 milligrams per deciliter with an estimated GFR of approximately 28. His transaminases, CBC, are within normal limits. His total cholesterol is 180, HDL is 30. He has a BMI of 28 and a hemoglobin A1C of 5%. Let's start a discussion talking about nucleoside reverse transcriptase inhibitor sparing regimens. So despite being the backbone of combination antiretroviral therapy, NRTIs can be associated with some complications. For example, with tenofovir, we do know that's been associated with disorders of proximal tubule function, osteopenia, osteoporosis, as well as osteomalacia. For abacavir, we know for patients who are HLA-B5701 positive, they are unable to take abacavir, and it should be listed as an allergy. And also there was a large amount of data centered around the use of abacavir and concerns about its use in patients with a high cardiovascular risk. So that's one area where we say we may not be able to use NRTIs. You may also have a patient who has a history of extensive NRTI experience and resistance. So this may be the patient that started out with serial monotherapies followed by dual therapy, and really what followed after that was occurrence of resistance to the whole class of NRTIs. And then finally, I think really important is as patients get older or our patients have other comorbidities, we do know that there may be changes to the estimated GFR, and we know that we need to have some drugs, particularly the NRTIs, that need to be renally adjusted. And when we do that, this could actually complicate the dosing. For example, a single tablet regimen where a patient takes a tablet once a day. Now we have to break up the components, and one component will be taken maybe every other day, every 3 days, where the other one piece of that regimen will be taken once a day. And then there's some regimens where you're unable to break it up because some of the components are not available. So that would be a reason also to consider NRTI sparing regimen. So what are the available 2-drug single tablet regimens? So I've listed them both here. So the first one is the co-formulation of dolutegravir and rilpivirine. And what I'm doing is listing the indications here for you. So this is indicated for the treatment of HIV-1 infection in adults to replace the current antiretroviral regimen in those who are virally suppressed. And that's defined as an HIV-1 RNA less than 50 copies per ml on a stable regimen for at least 6 months with no history of treatment failure and no known substitutions that would be associated with resistance to the individual components, and that would be both dolutegravir and rilpivirine. So here we have a integrase and an NNRTI based 2-drug regimen. The second one is dolutegravir and 3TC. So this is indicated for the treatment of human immunodeficiency virus type 1 infection in adults with no antiretroviral history, or to replace the current antiretroviral regimen in those who are virally suppressed. And again, this is defined as an HIV-1 RNA less than 50 copies per ml on a stable regimen with no history of treatment failure and no known substitutions associated with each of the individual components. And in this case, we're using dolutegravir 3TC, so we're using an integrase inhibitor and an NRTI. Let's look at some of the data that led to the approval of each of the 2 single tablet regimens. So the first one is the SWORD 1 and 2 study. And what this was a switch to dolutegravir rilpivirine versus continuing the baseline antiretroviral in patients who are virally suppressed. So it was a parallel randomized open label multi-center phase 3 non-inferiority study in adults who were on stable ART regimens, and that could consist of an integrase inhibitor, an NNRTI, a PI, plus 2 NRTIs, and they had to have a virus load less than 50 copies per ml for greater than 6 months, and they were randomized 1-to-1 to either dolutegravir rilpivirine, which we consider the early switch, or they would remain on their combination, and that would be considered a late switch because they would switch after week 48. So looking at the primary endpoint, at week 48, HIV-1 RNA less than 50 copies was maintained in 95% of the patients in each arm with an adjusted treatment difference of minus 0.02%. And at week 100, the HIV-1 RNA being less than 50 copies was maintained in 89% of the early switch versus 93% in the late switch arm. When you look at confirmed virologic withdrawals through week 100, there were 10 out of 990, which came out to be 1%. When you look here at the bottom, what you see is a list of treatment emergent NNRTI resistance mutation that was documented in 3 of the 10. They all came from the early switch arm. And if you see here, you can see the time of the failure. So one was at week 36, one was at week 88, and then one was at week 100. You see their previous regimen there. You see what mutations they had at baseline, whether you're looking at the NNRTI or the INSI class, and then again, confirmed virologic withdrawal and what were the mutations. So again, you see for the first case at week 36, you had development of an NNRTI mutation. For the second one, NNRTI, and then for the third NNRTI, you had 3, and there was failure there to detect any INSTIs. And then for the 3 patients we just talked about, the viral load at the last measurement was less than 50 copies, 55 copies, and 300 respectively. So what's some of the real-world evidence with use of dolutegravir rilpivirine in the United States? So this was a really great study. It's a retrospective analysis of the clinical characteristics and outcomes in people living with HIV who were switched to this dolutegravir rilpivirine. And this took place between January of 2018 and December 2018 in the OPERA study. And the N was 880. You can see some of the baseline characteristics. And what I think is really important is really 2 pieces. So if you look at the bottom, so look at some of the baseline demographics of patients switching to dolutegravir rilpivirine. What you see in blue is about 63% were from the South, 54% were older, defined as 50 plus, the risk factor being MSM, race being Black 35%, ethnicity being Hispanic 28%, and then female, as always, lower percentage, but about 18%. But again, compared to the overall population, it was very similar. And then look down at some of the comorbidities. Again, you could go through each one, but I think the one we highlighted here, because it kind of goes along with our case, is renal disease. And what you see is for those suppressed, 198 or 29.5, and then not suppressed was 51 or 25.9. So again, this is looking at just real-world evidence of where people are using dolutegravir rilpivirine in the U.S. One thing to remember when switching to rilpivirine is the problem you may have for patients who are taking acid-reducing therapies. And what we do here is we break up the 3 types of agents that are commonly used when someone presents with heartburn or GERD-type symptoms. So the first one is a prescription of antacids, and there's multiple different types. So aluminum or magnesium hydroxide, calcium carbonate. So what are the effects on rilpivirine concentration? So there really is no change if the antacid is taken greater than or equal to 2 hours before rilpivirine or greater than after 4 hours after rilpivirine. So Key is to use antacid and rilpivirine with caution because it may decrease the rilpivirine plasma concentrations. And this is really important when you are doing education with patients about use of these drugs or if they have heartburn symptoms. I think the other key that's really important for this is education for patients who may be seen by other outside providers. So the second group are the H2 receptor antagonists, and there's listed a couple. And what you see is that there's no change if the famotidine is taken greater than or equal to 12 hours before the rilpivirine or greater than or equal to 4 hours after the rilpivirine. Decreased rilpivirine if the famotidine is taken 2 hours before rilpivirine. So it's really key when talking about spacing out this regimen. And as we said, you got to use this with caution. It may decrease rilpivirine plasma concentrations. The third one I feel is the easiest, but the most problematic. This is all the proton pump inhibitors. So if someone has maybe failed antacids or H2 receptor antagonists, they may frequently move to a proton pump inhibitor, or if there's evidence of esophagitis or inflammation on endoscopy, they would be prescribed a PPI. And we know that PPIs decrease rilpivirine plasma concentrations due to gastric pH increase. And so the recommendation here is a little different than the other. There is no spacing out recommendation. This is a do not co-administer proton pump inhibitors with rilpivirine, and this may require a switch of the regimen. So this is something important to consider when you are looking at using this two-drug combination that still has rilpivirine. How about some of the other data that's for switch when we talk about dolutegravir 3TC? So initially, we only had one study, which was the TANGO study, and recently, due to a poster that was presented to SALSA, we now have two. So TANGO was a switch to dolutegravir 3TC in virologically suppressed adults who are on a TAF-based regimen. So as you can see here, this was a multi-center randomized open-label phase 3 non-inferiority study. You look to the left here, you can see the criteria, and a lot of them are very similar to what we see in switch studies. So patients had to be on a regimen, they had to be suppressed for greater than 6 months, and here at this point, this was on a TAF-based ART. They could not have previous virologic failure, current hepatitis B, or hepatitis C that would require therapy. And I'm going to come back to the Hep B in a second. They also had no major NRTI or INSTI-RAMs, because again, you're now switching to a two-drug regimen. Just one thing to mention is keep it in mind that when you are switching someone to a two-drug regimen, it's always important that you remember to look back and see what is the hepatitis B status of the patient before you switch. So these patients were randomized, as you can see here, 1-to-1 to switch to dolutegravir 3TC or to continue on their TAF-based regimen, and then they would switch at a later date. And then they were all continued on after week 196 to continue dolutegravir 3TC. And the primary endpoint was HIV viral load greater than or equal to 50 copies at week 48 by snapshot with a non-inferiority margin of 4%. And again, this primary endpoint may look a little different to individuals. Most people are used to looking at less than or equal to 50. And remember here, this is a switch study with patients who have no virologic failure. So you're looking at different points here, and that's really looking at greater than or equal to 50. And what you see at the top of the snapshot is very similar rates compared to the two. So 93% who switched to dolutegravir 3TC, 93% for those who continued on their TAF-based regimen, and it met its definition of non-inferiority. So we concluded that dolutegravir 3TC was non-inferior to continuing on a TAF-based ART. Now we're going to talk about the SALSA study, which was a switch to dolutegravir 3TC versus continuing any three-drug ART regimen. What was different here compared to TANGO is that in TANGO, all patients were on a TAF-based regimen, and in SALSA, patients were on any different combination of NRTIs, which I'll cover in a second. So this was a multi-center randomized open-label non-inferiority phase 3 study. Inclusion criteria were a little different when compared to TANGO. So you had adults with HIV-1 RNA less than 50 copies per ml for greater than 6 months and greater than or equal to 3 months on any uninterrupted three-drug combination. And that could consist of 2 nukes plus either an integrase inhibitor, an NRTI, or protease inhibitor. That have no prior virologic failure, no documented NRTI or INSTI resistance, no hepatitis B as we discussed, or Hep C required therapy. And here the primary endpoint was very similar. So it's participants with plasma HIV-1 RNA greater than or equal to 50 copies at week 48, and they used a snapshot analysis. Some of the baseline characteristics, which I think are interesting to talk about, was the third agent class. And so if you look, about 40% were on an INSTI, 50% were on an NNRTI, and 10% were on a PI. When you look at the NRTIs received at screening, and greater than or equal to 30% of the participants, when you look, TDF was seen in 44% of patients, and TAF was in 34 versus 37 in those who continue on the regimen. So it was a little different background compared to the TANGO data. And again, when you look here at the top right-hand corner, and when you look at the snapshot analysis at week 48, it's really clear that switching to dolutegravir 3TC in virologically suppressed patients on a 3 or 4 drug regimen demonstrated non-inferior virologic efficacy to a variety of different ART regimens through 48 weeks of treatment. Now we are going to hear from my patient on his perspective about making this change from a 3 to 2 drug ART regimen.
But looking up the information that he gave me, he was like, this is a pretty much a new drug that's out, and this will help more of your medical conditions than taking the other pills. This is going from 3 to 2. And of course, my first question is, well, hey, I'm getting 3 meds in one. Isn't 3 better than 2? But it was more, although there were 3 different drugs in that, the two drugs that were in my current medication was able to handle all of my other medical needs as well, or assist with it, or assist with stabilizing my different medical conditions.
So what are the key take-home points from this key decision in HIV program? So we know that NRTIs do serve as the backbone of most ART regimens, but there are reasons to consider using NRTI-sparing regimens in clinical practice. There are 2 FDA-approved 2-drug single-tablet regimens available. One is dolutegravir rilpivirine, and the other is dolutegravir 3TC. And always remember, when switching ART regimen, it is important to review prior history of ART regimens and prior resistance before making that switch. So thank you again for tuning in today to this program. Go online for more CCO activities on key decisions in HIV care. There are also medical minutes and podcasts with expert faculty, clinical thought commentaries from physicians and patients, patient education sheets to print and share. And what you see there on the left is the website. It's clinicaloptions.com/HIV. Thank you.
Thank you to Dr. Short, and thanks to you, the listener. To listen to more episodes in this series and to see slides and webcasts on key decisions in HIV care, see the links in the show notes. Thank you and have a great day.